And we are live.
Okay, thank you. It is, this is the Senate Health and Welfare Committee back, January 20th. And we're moving on to hear from Dr. John Saroyan, who from the Blueprint for Health. And so Dr. Saroyan, welcome. We'll go around and introduce ourselves and then have you introduce yourself for the record. So.
Hello, I'm Martina Rock-Ulick. I live in Burlington and I serve Chittenden Central. Thank you.
Good morning, Dave Weeks, Rutland County, and I come from Proctor.
Terry Williams from Rutland County. I'm from Pullman.
Ruth Hardy will be in just a minute from Madison, and she's not in Madison right now, but she'll be back in. And Ginny Lyons, and we have that.
John Saroyan, Executive Director for Blueprint for Health.
Okay, so you're going to give us the Blueprint 101, and we'll look forward to it. So are you going to share your screen? Good.
Thank you, Madam Chair, for inviting me to present to the committee this morning. I have been looking forward to reviewing the Blueprint with you all. The statutory framework for the Blueprint for Health was established in 2010 through Act 128. The Blueprint has 15 years of experience as to how healthcare is distributed statewide. Through research, design, and implementation of innovative healthcare delivery and payments models, the Blueprint remains a multi-payer, whole population program that can develop and test healthcare reform initiatives. As an innovation engine, it has implemented concrete and durable changes to treatment delivery, payment models, and healthcare information systems, particularly related to integrated primary and community care. The Blueprint for Health is ambitious in its goal for Vermonters' primary care providers to be supported in taking a long-term, whole-person approach to care, one that addresses medical, social, and mental health needs and provides access to a range of supportive services in an integrated fashion. For primary care providers, the Blueprint for Health can encourage an expanded focus on the needs of the entire population they serve. The program has offered support through delivery system reform and payment models that give primary care the ability to invest time and resources in team-based, data-driven, quality-focused care. In accompaniment to this slide, you all should have an additional document entitled Blueprint for Health, Internal and External Return on Investment. This is a topic I plan to return to in the future, Senator Lyons, but did want to let you all know that the external and internal evaluations that have been done for Blueprint for Health are been done robustly and showed positive return on investment. And I will leave this for maybe a future discussion if that's
Absolutely.
okay with you.
Yeah, good.
And
Thank
you all, of course, are welcome to do that.
Okay, great.
The Blueprint Executive Committee is defined in statute by the members representing departments and agencies of human services, including the Department of Health, Department of Mental Health, and the Department of Vermont Health Access, as well as a representative from the Green Mountain Care Board. 2 private health insurers are represented. Healthcare professionals who provide health services are represented, as well as healthcare associations and consumers. Representative Lori Houghton is an individual appointed jointly by the President Pro Tem of the Senate and Speaker of the House of Representatives, and she joined our committee last year. Health service areas represent the areas in which patients receive their health care and historically have been defined by which hospital they have been discharged from. This is a term among many that I included in a glossary for you all that's quite particular to the Blueprint. Blueprint utilizes health service areas to help ensure that resources are distributed across the state in a way that is accessible to most people. Also shown here are our current program managers. And I'll talk to you all about program managers and define their duties as well.
Are each of these folks at a hospital or?
2 of them are at federally qualified health centers, Madam Chair, and the rest are at hospitals.
Thank you.
Of course. Each administrative entity hires a Blueprint program manager to oversee Blueprint activities in their health service area. The program program manager is the primary contact locally responsible for management of all programmatic and administrative components of the agreement. They provide support and help in the development of effective strategies in alignment with grant and program deliverables. They establish key relationships with patient-centered medical homes, a term that I'll be defining more completely soon, community partners, regulators, and governmental agencies. The Blueprint program manager is also the key liaison for Blueprint trainings, strategic direction, coordination, and support in developing and spreading best practices. Next, I will be reviewing Blueprint programs, including the patient-centered medical home model and quality improvement facilitation, community health teams and defining them, as well as payment systems for both, the hub and spoke system for opioid use disorder treatment, and also the pregnancy intention initiative. And if I haven't said it before, I say it now. I'm happy to pause and entertain questions whenever you feel is appropriate.
Oh, it's up to you.
Okay, I'll keep going.
You're in charge.
The Blueprint was founded on the establishment of patient-centered medical home recognition by the National Committee for Quality Assurance. Practices that meet their standards have been shown to help better manage chronic conditions, improve quality, and are associated with lower healthcare costs. The Blueprint supports practices that become recognized as patient-centered medical homes through supplemental or additional payments to support their work. They still bill the way they would normally bill, and these are supplemental payments, and I have a very detailed slide about all those amounts and that background. These payments are made by public and private health insurers directly to the practice. The practice and practitioners know their patients, they understand their health history and needs, their preferences, and those are taken into consideration as prevention strategies, new and longstanding healthcare needs are met in context with their goals. There's also expanded access to the provider and care team through electronic communication, extended hours, after hours coverage, and screening procedures are done regularly based on the patient's age and gender. There is assistance with managing various specialist referrals, referral follow-up, care planning, as well as coordination of that care. All together, it's an approach that emphasizes and supports informed decision-making, motivational interviewing, the patient-centered goal setting, and self-management of chronic conditions. The Blueprint also supports the patient-centered medical home practices with a quality improvement facilitator. This is a professional who uses evidence-based tools to help the practice meet key healthcare quality metrics and make sure that they are maintaining their recognition as a medical home.
Just to interrupt you here, but to let folks know that your script is also on our webpage. So you have the slides, and then you also have the script, which is very helpful.
Sure, and the glossary of key
And
terms,
the glossary.
which I refer to frequently. Just,
Love a glossary.
We love it.
it's also very carefully referenced. Thank you to my team. So shout out to them. Okay, payments, patient-centered medical home. The patient-centered medical home payments that the committee sees on the left side of the screen represent the current per member per month amount paid by commercial, Medicare, and Medicaid payers. The commercial and Medicaid payments have not been increased since 2016. The Medicaid payment is higher than the commercial payment because it incorporates a pre-existing payment for managed care services. The Medicare amount is based on available shared savings amounts that are determined from the all-payer agreement. Half of the performance payment, so this is the middle text that you see, patient healthcare utilization, is based on healthcare utilization of the patient population of individual practices up to 25 cents per member per month. So that number is multiplied by everybody in their clinic that falls under these categories. And the other half is based on hospital service area population, healthcare quality measures, also up to 25 cents per member per month. To give the committee an idea of how these payments might accrue for a small practice of providers, for example, I took this from an example of maybe 2 physicians, 1 nurse practitioner, just on the smaller side. I present you with an example of the dollar amounts per insurer, as well as the total per month that would be paid. And again, this is an example. This is not an actual practice. This funding is used at the discretion of the practice, that medical clinic, the doctor's office, in more commonly used terms, related to maintaining that high level of recognition as a patient-centered medical home and activities therein. I started with the darker green circle, which is where people receive their care. I'm moving now to a slightly lighter green circle that I'll go through with you all to show you the next layer of funding that's directed by the Blueprint for Health, which is the community health team. The community health team supplements the services available in the medical home and links patients with social and economic services that make healthy living possible for all Vermonters. The community health team staff are intended to provide supports and services that are not generally covered by insurance at no cost to the patient and without regard to insurance status. These staff may include social workers, coordinators of their care, mental health counselors, dietitians, community health workers, and other types of professionals who provide and support whole person care. The community health staff are intended to provide supports and services that are not generally covered by insurance. So these individuals working for the community health team do not bill for their services when they're in their role for the Blueprint. And there's no money extracted, there's no bill for that service that the person would get. And it's provided without regard to
I
insurance
have a
status.
question and you have a question. My question is, how is the care management facilitated from the service to the outside ring? And then Senator White, go ahead and Harder, ask your question and we'll try and get.
My question was, so the slide that you showed where for how the payments work.
Should I go back to it?
Sure.
Yeah.
Is this all the 2,300 people at the bottom? Is that all the patients in the practice, regardless of income and regardless of what, how often they're seen by the clinic, et cetera?
It is not all the patients in the practice. And the second part of the question was how often they're seen. Say that part again.
So this is, so who are they? If they're not all the patients,
Yeah,
how are they?
So the total of number of patients who receive the majority of their primary care services at a specific practice within the past 24 months, the Blueprint has a methodology that the insurers, the payers, follow to combine the individual with their payer. So there are payers, for example, for some patients who are exempt from the statutory inclusion of being a Blueprint provider payer, and those payers do not pay in. So we have a very specific formula that's followed. It's a look back of 24 months for a primary care visit that qualifies. And if a person is insured by a certain type of insurance offered by Blue Cross Blue Shield, MVP, Cigna, all of Medicaid, all of Medicare, then that individual is included in this attribution model.
So it's only the patients who are covered by these types of insurance.
And this is in my glossary of terms as well, individuals for whom there is, and this part's always good to drill down on, so thank you for pointing it out, that it's for individuals who are wholly insured. So this is not inclusive of individuals for whom their employer, let's say, is in a administrative services only or claims-based way of paying. This is individuals who have health insurance that are, do you mind if I show you in the glossary where it is? Because it's hard for me to explain extemporaneously sometimes.
It's hard for me, I'm not understanding who the patients are that
So,
are covered.
The Blueprint attributed patient population is the total number of patients who've received the majority of their primary care services from the providers in the past 24 months. And that number is used by participating insurers to determine the practice's caseload. Excluded from that would be things like a third-party administrator, so a company that contracted a health insurance provider to perform just the administrative duties of payment.
So because my health insurance is from a self-insured employer, I wouldn't be an attributed patient for the primary care practice that I go to, because my insurance is not through one of those.
So the presence of your visits during a 2-year look back, that, out of one would not occur in that arrangement of self-insured payers.
So I would not be included. I'm trying to get you to say this in simple language, and you keep saying it in complicated language.
Oh, okay.
So because my insurance is through a self-insured insurance plan, I wouldn't be counted as one of the patients.
In the attribution model.
If I were on Medicare or Medicaid or had my primary insurance through Cigna, Blue Cross, or MVP, I would be counted, regardless of income, whether I made $20,000 a year or $250,000
To my
a year.
knowledge, yes.
Okay.
And you still receive the services.
And what if I don't go every year? What if it's only every other year? Is it only any patients who's technically an enrolled patient at a practice, or do you have to actually have had a visit during that
It's
year?
a 2-year look back. It's a 24-month look back.
It's a 2-year look back to have had any kind of
it's
visit
it's a super long list of different types of visits.
Okay.
Yeah, that fall into the rubric, and actually we even include, yes, we include a wide variety of codes for what counts as a primary care visit.
Okay.
So, yeah, this is very good. This is helpful. If her self-insured coverage includes Blueprint coverage, then does that happen?
I don't know of a
We don't know.
self-insured program
We don't
that is a payer, because they're exempt from
Yeah, I know they're totally
contributing.
exempt, but if they wanted to, welcome to the
Let's talk,
club.
yeah.
Right, okay, that's all.
I mean, I don't know that we direct payments from any.
No,
I look at all of them and
yeah.
don't remember seeing one.
So the state health insurance plan are state employees or the NEA?
That's a third-party administrator arrangement, and to
Yeah.
my knowledge, that's not a,
Yeah,
Blueprint.
to my knowledge, it's not.
and the same with the teachers. And yeah, there are a lot of people that.
Hello. Yeah, okay.
Community health teams, or no, you have a question, I'm sorry, so
Yeah, no,
care
it
management.
was just about care management. I
Sure.
was saying up at this level, so.
Yeah.
And how it's paid for and coordinated. You've got a health team there, so whether it's SASH or the hub and spoke, I go to there, someone, you have a nurse care coordinator. Is that the person that helps to connect each patient with the external care that they need? How does that work?
Sure, there are care coordinators that are in the clinic, if that's a priority to how the clinic is expending its resources. There are also care coordinators on the community health team, and those individuals would make sure that they're not overlapping or doing duplicative services, but they would they'd work in concert and decide who has the expertise to manage that person's issues. As you may not know, I visited every site except 2 last year, and learned in quite a great bit of detail the implementation of these programs specific to care coordination and other services, and how practices work with community health teams. And I saw both models of care coordination. I saw models of care coordination, which is fine. I saw models of care coordination where the individual was in the practice, and I saw models where the practice would reach out to a care coordinator in the community, but external to their physical location for assistance with figuring out referrals, following up on labs, helping with transportation, et cetera.
I just thought of a question I
Sure.
need to ask somebody else because you
Oh, okay.
popped it into my mind. Go ahead.
All right. Community health teams supplement the services available in the patient-centered medical homes and link patients with social and economic services that make healthy living possible for Vermonters. The community health team staff are intended to provide support and services that are not generally covered. And I'm realizing I have read this already. I think I will go to slide 14. One of the key functions of the community health team is to serve as an access point to specialty supports and services already existing where the patients live. So despite it being blue, the outer circle is not, does not represent agencies or groups that receive funding directed from the blueprint, but this is the community supports and specialty supports that our community health teams link individuals with. And these may include food, housing, transportation services, specialty and disease management, and the other aspects of this slide. There is the self-management program, which is an exception to what I just said, that actually is a link between the Blueprint for Health and the Department of Health. The Department of Health implements local programming for the Blueprint about self-management at myhealthyvermont.org is where signups for all the different hypertension, diabetes, and other self-management and education programs are, which are evidence-based and led by facilitators. So the payments, the Blueprint support staff of the community health team by directing public and private health insurers to make payments to the administrative entity, a term which I haven't defined yet, but I will, in each region of the state. Usually the local hospital, but not always. Sometimes the federally qualified health center is considered that entity in a health service area. Blueprint funded program managers oversee the outflow of funds to local practices to make sure that the needs of the community are being met and that practices have the appropriate level of support. Medicare funding availability has not kept up with the past payment increases of both commercial and Medicaid. So in the middle slide in the dollar amounts, one can see $2.77 for commercial insurers and $2.77 for Medicaid and $2.51 for Medicare. And I'm going to show you a next sort of a similar type of slide as I did before. It's an example. On the left of your screen or the right? On the right side of your screen, I share with you 3 different ways by which staff can be employed. One is the actual entity receiving the money directly hires the staff member and deploys them. The second is that the entity contracts with a local provider, such as a designated agency, and what we call a pass-through of those dollars. And then the other is that the clinic or the practice itself receives funding to hire staff that it chooses and hires.
How are the administrative entities at the local level chosen, the hospitals versus the FQHCs? And how do practices become part of the Blueprint? And how do you ensure sort of equity across the practices that are part of the Blueprint? This is a concern I've heard in my community, that not all the practices that are part of Blueprint feel like they get as much support and attention and resources.
Equitable treatment.
Yeah,
Yeah.
that as others, and there's concerns about who's sort of is controlling it at the local level.
The first question regarding how administrative entities are chosen, historically, I don't know. In my year of being the executive director and in my visits to all of the, except for one, administrative entities, it's a lot of administrative work. It's a lot of administrative entity takes on a great deal to manage the funds that are directed. And what I heard as I went around the state was, to do all of this work, John, we need more. We're investing our own dollars in administrating the funds you give us. And
So historically, it would be something maybe you could bring back to us at some point.
it could be,
Yeah.
and I can certainly ask. I don't know how that came up. I can certainly ask and bring up, and I have to, with my team and with my own work, make those assessments to see how well are they following our guidelines, how well are they participating, how equitably are they distributing things, how responsive are they to corrections or changes that we might suggest. But I certainly can ask my team and bring it back to you. I don't know the origins of the beginnings. How do practices become a part of the blueprint? The program managers are tasked with the responsibility of reaching out to all non-participating practices on an annual basis. They're also charged in their quarterly reports with giving some mention of that, though it's really an annual reach out that they're expected to do. And I'll just give you an example of a practice that was interested. The discussion usually begins with the program manager. This person wanted to speak to me, so they came to Waterbury and met with me for an hour to review the blueprint program, similar to the presentation I'm giving you all. And that's where the discussion begins. And then the assistance comes in a person on the team that I haven't spent a lot of time speaking about, but is known as the quality improvement facilitator. The quality improvement facilitator really works intensively, especially in the beginning, but also over time, so that the practice can meet the high standards in its own practices and policies and procedures of becoming a patient-centered medical home. So that's the process on that side. The equity across practices question, in terms of how dollars are distributed by the community health team, is an area that I've taken a lot of interest in myself, and asked those questions of both the administrative entity, and in some cases tried to listen to practices themselves, either that reach out to me or that I've heard don't feel like they get their due. And those are tricky one-by-one situations that, as an executive director, I need to make a judgment myself about how far I go in, how far I coach, how far we support the program managers and the practices with what the rules are, to make sure the rules are well understood and well implemented. And that's an ongoing part of my responsibility to continuously, with the team, evaluate when those concerns come up, encourage people to bring them to me, because they do. This is precious resource. Practices can feel on either end, and I'm not sure, Senator Hardy, if I'm answering your question, but it's an ongoing oversight of funds, where, as executive director and as a team, we have to remind people of the rules of the state, and we also have to work with the administrative and entity and program manager to remember that it's all the blueprint practices in their area. I feel like, for the most part, I've been very fortunate that that hasn't come up too much, but it definitely does arise.
And do you have some kind of evaluation process for the local administrative entities and the practices themselves? So
an evaluation process for the administrative entities. I do not have an evaluation process that I know of. This year, I am planning on, and I haven't begun it yet, meeting with the CEOs and the CFOs of every administrative entity to review the rules of engagement with the blueprint. I found that last year there were so many new people in leadership positions, and that pandemic and the few years before the pandemic, that that frequent contact with the executive director and why things should be spent on what they are and what the rules are, that these are state-directed dollars, have been followed. I will share with you the next time I come, a distribution, and I don't have that slide today, but I hope the next time I come, share with you how the community health team dollars are spent by different positions. That's something I think
Yeah,
the
that'd
committee
be
will be
good.
interested in.
Yeah.
That was what I was very interested in last
Yes,
year.
I
And we
know.
spent much of the year collecting that information so that we know how are these dollars being spent on what, where. So
And the outcomes. So, yeah, this is good. I think this is a great introduction to that conversation that we will have, so.
And-
why don't you just,
okay,
go
so
ahead.
similar to the example I presented to the committee for the medical home payments, this slide depicts, and again, this is to some extent, I made this up based on a number of different areas. What one administrative entity could receive based on their attributed population, so not their entire population, but the attributed lives that meet the formula for Blueprint. So on a monthly basis for the outer ring of kind of darker green, for them to hire or pass through or pass along dollars, they might be receiving as much as $107,000 monthly. And those payments are sometimes put quarterly or monthly. This dollar amount is what it would be on a monthly basis. This is a 12,000 attributed patient population. That's still on the small to medium size. So I kind of weighted my slides more towards health service areas that were not geographically smaller, but the numbers are
The services.
smaller. If we move to a different county, I might have an attributed patient population of well over 100,000. So those are the dollars. In addition to the community health teams, there are 2 additional key programs sponsored by the Blueprint that patients may interact with in their medical homes. The Hub and Spoke is Vermont's system of treatment for opioid use disorder, with 9 regional hubs under the direction of the Department of Health, as well as daily support for patients with complex addictions. At over 75 local spokes, so these are office-based treatment of opioid use disorder, doctors, nurses, and counselors offer ongoing opioid use disorder treatment that is integrated into their healthcare. This really reduces stigmatization and contributes to their whole wellness and normalizes the treatment of opioid use disorders as opposed to separating it out from what people may feel is regular, in quotes, a medical care. So it normalizes the inclusion of that service into a medical home. This framework utilizes medications for opioid use disorder for treatment and deploys expertise in addition to that, counseling and care coordination into the community, and links them to the specialty centers, the so-called hubs. As you can see in the right-hand column here, there's been quite a growth of patients that have participated in the Spoke program since its inception in 2013.
While we're talking about this, I know that Senator Hardy is very much involved in the use of the dollars we're getting from our the first pharmaceutical settlement.
Oh,
And
the opioid settlement agreement?
Yeah, so, and one of the questions that I asked at a meeting with, I think it was DEBA folks, and Ina Backus was there, I think, is, are those dollars able to be matched, Medicaid matched? And the answer is yes. So that will have an important, that's important for us to know, and particularly here where we're looking at Hub and Spoke. Anyway, just an aside.
The Pregnancy Intention Initiative helps ensure that women's health providers, medical homes, and community partners have the resources they need to help women be well, avoid unintended pregnancies, and build thriving families. In 2017, what was then called the Women's Health Initiative, we're moving the name to something that's more inclusive, I'm calling it the Pregnancy Intention Initiative today, was begun in an effort to increase the intended pregnancy rate. As of 2020, the intended pregnancy rate in Vermont was 57.1%, an increase from 55.9% in 2018. On this slide, there are multiple components that you can see of the program that include family counseling, psychosocial screening, intervention, and then referral and assistance to other services that might be needed. Central to the data that is collected and the counseling that goes on, the assessment, is the would you like to become pregnant in the next year, which is known as the part of the pregnancy risk assessment and monitoring system. Yes.
Just to make sure I understand this, you're saying that intended pregnancies are not even 60%, so over 40% of pregnancies in Vermont are unintended?
That's correct.
How does that compare with other states? Do we know, can we get that data?
Sure, yeah, that seems,
that'd be,
yeah, that seems pretty. Sure. And I'll just make sure I have that next
Yeah.
time I come back, and if it's a link, I'll send it to Alex,
Perfect.
very simply. The, as of 2022, attributed patients numbered 22,000, and payment schemes include $1.25 per member per month, which is just goes to those practices. There's also support for staffing through the community health teams for the Women's Health Initiative when it's in a medical home. Alternatively, some OBGYN practices in the state participate, and they actually receive funding directed by the Blueprint to hire a mental health clinician. There's also a one-time per member per month, one-time per member payment to support those practices in keeping in their inventory effective contraception as well as long-acting reversible contraceptive devices. Thank you.
Wow. So maybe you could just talk briefly about the hub and spoke. I mean, we will be looking in here if that bill ever gets finalized. The expansion of hub and spoke to include more than opioids. I mean, that's my bill, but my intent, and I know it's maybe synchronous with yours. So could you just talk a little bit about how the hub and spoke works
Sure.
on the ground?
Sure. So the hub and spoke model was considered a novel approach to the services of evidence-based medication-assisted treatment for opioid use disorder. So that's where it started. So opioids, and that might be a little jargony, morphine, heroin, over the prescription oxycodone, OxyContin, medications, certainly in my practice, when I was practicing, that I saw people develop use disorders from. So the treatment of that type of use disorder has a medication known as buprenorphine, in addition to other medications that in my physician brain is quite elegant. It's a medication that prevents withdrawal and also can have a very, not for everybody, but for many people, a very quick effect of being able to stem their addictions, their use disorder. So the hub and spoke program was developed to increase the number of buprenorphine prescribers in Vermont, but also to provide individuals who are struggling with these use disorders the option of counseling, and also the option of care coordination, because there are frequently not just a use disorder that's going on, but perhaps mental health needs, other medical conditions like hepatitis, to really coordinate their care. The hub is the specialty area, and those are distributed around the state for individuals who need daily monitoring and daily medications. And that would be, for example, someone whose mixture of different medications reached such a high dose, perhaps that they really weren't fit to be seen every week. They needed to be seen every day and monitored closely.
Ginny, hub and spoke isn't unique to Vermont, is it?
Do you want to talk about?
Yes, yes.
How
It's
where we
been-
are
it's
with
been-
that in the
it's been-
country?
It's been hard to keep up. Multiple states nationwide have replicated Vermont's model, and other conditions have utilized the terminology hub and spokes beyond use disorder, both in the state, and I saw the term hub and spokes used in California's wellness for aging report. So it's
taken
not
off.
trademarked.
No, it's taken off, right?
Yes.
Vermont really is the leader in this area, and that's why I wanted to emphasize it a little bit. And we're learning the need for mental health counseling as well, so that we may be seeing that in legislation.
And I didn't emphasize it in my slides, and I probably should have, though it's very much in the glossary, the Pregnancy Intention Initiative, Women's Health Initiative, and also the spokes are funded only by one payer, Medicaid. So similar to what I probably didn't speak to as directly as I could have around medical homes. Every person who comes into that clinic setting receives services. Only individuals with Medicaid draw that additional piece of funding. So
if someone has coverage from MVP and they go into the hub and spoke system, then they're only covered as much as their insurance.
So that gets very much into the particulars, which
Yeah.
are hard for me to speak to.
Sure.
MVP has, if my memory serves me correctly, MVP has more than just fee-for-service
Okay.
billing. I believe another commercial insurer in the state does too.
Is it
But
Blue
in-
Cross and
but in-
Blue Shield? Do they have something? I see Rebecca over here.
I think so. I think it's MVP, but it's not every single patient that's served in spokes. I think it's more limited to certain areas, but certainly they still bill for fee for service. They still get billed for medication. It's this additional support staff that's primarily in terms of blueprint directed funds, and those models are outside my scope
Sure.
of knowledge,
Yeah.
or Medicaid only.
Okay. Yeah, good, thank you. I know historically, I think back to the origins of this, and we used to sit here and listen to people who had to travel 2 hours a day to get their methadone treatment. They had, they lived up in the Northeast Kingdom, and the only place they could get methadone was in Burlington, or they had to travel down south or from the south. So it was really inappropriate for the care that they needed. And so then gradually the hub and spoke evolved, and then the type of drug treatment would also evolve from there. And then we've changed who can do what when within the hub and within the spoke. It's been an evolution, but the whole time your office, you and others who have been in that office have really demonstrated significant leadership for us and then across the country. So, yes.
Sure, yes.
Go ahead.
Can you give me an example of a patient-centered medical home?
Sure. Should I start with a place, or should I just start generally?
So a place of role.
Oh, well, the federally qualified health center is a patient-centered medical home. The Hogan camps, I've spoken to a number of times, and when I was listening to them, when I did my site visit to Rutland in October, I told both of them that they speak more eloquently about patient-centered medical homes than me. I followed up with them since. I was in touch with Dr. Bullock as well. We spoke I think in December. That's a patient-centered medical home as well. So those are just some examples in Rutland. I did warn the Hogan camps that they spoke so eloquently that I may recommend they speak, and certainly that would be. But they're just I've probably spoken to 30 or 40 or 50 clinicians over time, and I think that the two of them put it in more concrete terms than I ever could, because that's what they've seen it change their practice. They've seen it help them rise to a higher level of delivering whole person care than their training and all their good work as physicians could do alone.
What might be helpful is to get their contact information to Alex. So rather than, we have.
Yeah, I might warn them first.
Please, oh no, if it's appropriate.
Yeah.
But to probably come, it could be on screen, but to,
Oh, sure, I'm
talk
happy
with
to
us.
do that.
Yeah,
I'm happy to do that.
And because we've got field trips planned, but that one might be another one. We could do it next year, but it would be, I think, more appropriate to get them in a little bit earlier.
The pediatricians that I've spoken to around the state, too, I'm thinking of, should I say people's name in testimony? I don't want to put them on the spot, but I've spoken
If
to.
they're professionals and they're part of your system, it's probably okay.
Oh, okay.
You don't have to say that.
I'm thinking of Dr. Haig in Enosburg,
Yeah.
and similar to, I forget the Hogenkamp's first names, but the doctors Hogenkamp, I have been lucky enough to meet both community health team members and providers who speak about these programs and are able to share professionally, personally, the impact that they've made on individuals in their practice. That was definitely in addition to Scout Camp, that was the best part of my year last year, was making health service area visits, community health team visits, the stories that people tell, and my shock at listening to how much support they gave individuals in their communities. In a couple of cases, they actually, I'm just sharing this, Senator Lyons.
No, this is terrific.
So my beginnings were in pediatric palliative care, children who were terminally ill and had serious pain, and that's what I did. That was my work. I worked in hospice for similarly about 8 or 9 years, going into people's homes. For me to be astonished at the coordination that teams are giving individuals around us, I've seen a lot. And there's a lot of things I wish I could unsee. So to hear stories about how far they were going to keep, for example, someone home until they had placement in long-term care, and to do it regardless of the person's payer type, their insurance, to measure that impact is close to impossible in terms of sort of dollar objective terms. To hear the stories is, again, for me being not callous, but rather seasoned as a clinician, having seen a lot, they sometimes wondered why I was having such a astonished reaction, because their response was, Dr. Soren, we do this every day. We do this every day. We help people achieve their goals every day. That's our work.
So we did take a field trip as a committee a few years ago to Gifford, and there's a wonderful.
Yes.
Oh,
yes.
Sorry.
Yes. Yes.
know
I can show the Gifford. They call it the community help team.
Yes.
I think I probably spoke to the same person you did.
Did you? Oh,
I bet I did.
She was taking
Her stories
over
were
for the
incredible.
retiring, and
Mhm.
she's unbelievable in the gift that she gives to her community and to her patients. Yeah. So it's been a very rewarding transition for me, stepping away from, which is hard to do, 20 years of direct service and supervision. It's hard to step away from that clinical work. The stories and the individuals we get to support certainly make up for it. And I think, Senator Hardy, back to your point, knowing that their executive director, their leader, their team centrally is energized, is paying attention, is going out and visiting them and helping them problem solve when things come up that are good and sometimes more points of disagreement. I think that's been a very energizing component for our Blueprint funded staff. And it's enjoyable. It's good work. Senator, sorry. two more.
One more.
Oh,
And they're flexible, the plan is flexible enough so that they're making it work sometimes by themselves.
Yeah, and I think that I'm not sure where this is going with your question, but for me, having served in pediatrics and then also in adult hospice, one needs to look out for one's colleagues so that they are not setting boundaries, that's probably too strong of a term, but sharing the work with their team, speaking up when they're needing more help, because the inclination is to help that person until they've been helped, which is amazing, but can also, I talked to more people who said they've been on the community health teams for more than 10 years. I mean, it's the person you're talking about in
Yes.
Gifford, I'm thinking of Bennington.
Yes.
I mean, I can start picturing multiple people that I met. They're like, no, this is where this is the work I do. This is where I am
So,
now.
yeah, well, it's a powerful statement about who we have in our medical community and in our community services. We're so committed to people and helping.
I think that mental health came up, and in the broadest of senses, not just individuals with a diagnosis or a certain something or other, but just support, someone to talk to, someone to connect. There was one individual who calls a member of the community every day to check in. Now, as a physician, I mean, it doesn't matter there doesn't even have to be a diagnosis, but for her to call and check in with that individual every day, 5-10 minutes, that's what that person needs. That's what that member of the community health team does. And then there's other people that might spend hundreds of hours supporting individuals. It gets to the point where sometimes it's hard to even for me to believe, but that's what our community health teams do. I'm sorry, you had a question
I was
too.
just wondering if you could give me an example, a couple examples of the homes in the Burlington area.
I did and pardon me for not remembering practice names as well as I should. There was a pediatric practice, I believe in Essex, that reached out to me in my first month. And I don't want to make up the name under testimony. And what they do with community health team dollars to really individualize care for children and families is above and beyond what they get. And they certainly were making the point of saying you should be doing more. The practice that I visited, Dr. Stein is on the opioid resettlement. Is that what's the
Settlement Advisory Committee.
So I visited where Dr. Stein works, the federally qualified health center. So that's Community Health Centers of Burlington.
Yes.
I was wondering.
And we spent
Riverside
a few hours there, and wow.
Okay.
Yeah, it's fun.
It's inspiring to see what individual teams and practices, and I could go on with other ones too, but those were the ones that I reached out to most, or they reached out to me in one case, I reached out to the other with the federally qualified health center.
Here's what we'll do. This is sparking a lot of interest. So if you can get some names of folks who could come in and share their experiences and define for us very practically a community health team.
Yeah.
That'd be great. I don't know how much time we'll devote to it, but we'll do that. It'll be like our field trip into the Blueprint Community Health.
It sounds like I should recommend a couple people to speak just to the patient-centered medical home, or would you rather?
Yes. No, that's
so
good.
both. Okay.
Yeah, and then a little bit of the other, but
Sure.
we'll always do triage here and figure out what we can.
Sure, I can give that to you probably Monday, I'd say. Yeah.
Send it right to Alex.
I'll send it to you, Alex. Sure.
All right. So this is great, and I greatly appreciate the time. Again, you're coming in, and it's been quite an evolution since last year. Glad you're here, and thank you.
And
And
enjoy your work.
Sorry?
You obviously enjoy your work.
Oh, well,
yeah,
thank you.
so Alex, we're good to go offline, and thank you all. This has been a good morning.